Good evening, everybody. Firstly, I would like to thank the organizers to giving me an opportunity to speak at this first CME meeting. My brief is to talk on subtrochanteric non-unions, principles of management, and I hope I'll finish in time and not bore you to death. Subtrochanteric fractures account for about 30 to 34% of all the hip fractures. Typically has a bimodal age distribution. The younger age group people have high energy trauma, most oftenly after road traffic accidents. The older people have low energy trauma. This is especially seen nowadays with osteoporosis and following bisphosphonate therapy, typically called as the atypical fractures. The overall incidence of subtrochanteric non-unions and its subsequent failure of the fixation device is about 77 to 20% of all the subtrochanteric fractures which were fixed acutely. Coming to the literature, there's very few number of studies which deal on the outcome and the treatment of subtrochanteric non-unions. In fact, if you do an extensive PubMed search, there are only 7 papers which deal with this kind of complications, that is the non-union along with the hardware failure. Now, what is a non-union? Non-union is an absence of radiological progress of healing or a hardware failure which is more than 6 months in duration. Presence of infection is important to designate it whether it's an infected non-union or whether it's an aseptic non-union. I would not be talking much about infected non-union because this is beyond the scope of this 10-minute talk. I'd be concentrating mainly on the aseptic non-union of the subtrochanteric fractures. Now, we all know that subtrochanteric fractures are different. These are different from the, not only the fractures, but the non-unions are different from the intertrochanteric fractures in the proximal femur or the diaphyseal fractures and the non-unions below. Why is it different? Well, it is different because of these 4 reasons. The first one is the proximal fragment. The proximal fragment of the subtrochanteric non-union or a fracture is very small. It is very hard to get a good control over it, and it's very hard to actually stabilize these fractures. The other thing is that the medullary canal of the proximal fragment is quite wide when compared to the medullary canal which is in the diaphysis. So therefore, using a nail to stabilize such fractures in certain cases is very difficult. The other thing is the deforming forces. The iliopsoas, the abductor medius, the adductors and the hamstrings, they all work in opposite directions to give this grotesque deformities with which these fractures and these non-unions are involved. Apart from that, the biomechanical stresses are also the highest here. Koch in his pioneering work many decades ago told us that this area is subjected to almost 1200 pounds per inch square of stress. So no wonder these, you see so many of these implant breakages at this particular bone. The other and the last reason is the dense cortical bone. We know that this dense cortical bone is relatively avascular. It takes a long time to heal. So these are the factors why these fractures and non-unions are definitely more difficult and different to treat. Coming to the hardwares which are used in such cases, you have a choice of intramedullary as well as medullary implant. The intramedullary nails have the proximal locking device which gets into the head and to the neck component, whereas they can be shorter or of the longer forms. There are many of them which are available commercially. Coming to the extramedullary, you have the age-old DCS which we have been doing from a long time. The other implant which I would like to emphasize is the condylar blade plate. These 95-degree condylar blade plate is, although it's a little technically difficult, but once you get the hang out of it, it is an implant which will give you the best results in terms of stability and in terms of coring out the bone which is happening there. The recent addition is your locking plates, especially the proximal femoral LCPs. These are marketed by Synthes and also now by, what is this company? Smith & Nephew. Now, if you look at this picture carefully, you'll see that this is a common picture you'll see in a complicated non-union. You see that the nail is there, it has been locked into the intact lesser trochanter, but the proximal fragment is, not only is it abducted, external rotated, but it's also flexed in the lateral views. Now, this implant is waiting to fail. As it has been classically described, it's a race between union and implant failure. One thing to remember here is most of the hardware failure, it should be considered as a consequence rather than the cause of failure. It is because of the non-union that the implant fails, and it is not because the implant fails that the fracture goes into non-union. This is an important distinction. The intramedullary nails which have been used to fix these fractures primarily, they follow a specific pattern of failure. And this was very ably described by Peter Giannidis from Leeds. The pattern is so-called as the auto-dynamization. Initially, it is the distal screws which break off. This typically happens in about 4 to 5 months after the initial fixation, and followed by which the nail will break in the proximal portion at the lag screw insertion site. Now, why does it break at that insertion site is because this is the area where the nail tapers from a broadened proximal end into a little narrower distal end, and this is also the area where your lag screw hole is present. So therefore, there is a 70% decrease in the mechanical strength at this particular junction, so that is the reason why it actually fails here. Coming to the evaluation of these non-unions, needless to say, you need a complete medical workup. Infection has to be rolled out. The infective markers like CRP, ESR, CBP has to be done. In some cases, you might also need to do a bone scan. What is most important is to have good quality X-rays taken well. This is to not only to analyze where and how the implant is present, but to see how much of bone is left, but also to see and define the deformities. Ideally, you would see a abducted and an external rotated deformity in the AP view, and you would probably see a flexed deformity in the lateral view. CT scans are used. CT scan is sometimes used to make out the non-union and also to find out the implant breakage, because sometimes it's very difficult because there's a lot of bone and the implant shadow to make out what exactly is happening. CT scan is also important to actually make out how much of bone is left in that crucial proximal fragment. It is also important in cases where you want to analyze how much of malrotation has actually taken place. So coming to the surgical steps in dealing with these non-unions, most of these surgeries are done in supine position on a fracture table, that is so as to have an unhindered access to the CM and to visualize the proximal fragment well. You need all the armamentarium what it needs to actually remove this hardware. The hardware can be extramedullary or intramedullary, it can be intact or it can be broken. It's good to have a universal, nail removal set, which is illustrated on the top slide. If the implant is broken, and especially if it is an intramedullary implant, it is good to have one of these small broken nail retrieval sets, which is nothing but a long reamer, which is conical in its end, which is threaded. All you have to do is that you have to jam these conical threads into the broken distal part and turn it counterclockwise, and then you have to jam it out. For the broken screws, it is best to have all the hollow drill bits, hollow mills, and it refined so as to get the screws out. The crucial step in this non-union, subtrochanteric non-union, is to debride the non-union side. You have to be thorough, meticulous. You have to break down the non-union side. You have to remove all the fibrous tissue and the bone which is surrounding there. Take deep samples for culture and sensitivity. Needless to say, you have to respect the soft tissues. Sometimes these non-unions are so stiff that you can't actually get access into it. So in such situations, it might be a good idea to use a small laminar spreader which the spine kit has, and to pry it into the non-union side and open it off and then carry out with your debridement. Of course, the medullary cavity of the both proximal as well as the distal canals has to be opened up either with a drill or with a handheld reamer. So this is one illustration. This is a neglected subtrochanteric non-union. So you can see that it is not malunited as yet. It is in non-union, and it looks as though it is quite simple. You give it a traction and it's going to fall back into its place. Definitely not so. You have to open it out, and you'll be surprised to see that there's a lot of bone and fibrous tissue which has to get out. Okay, I'll just try to hurry it fast. The next and most crucial step is the alignment of the fragments. You have to reduce the fractures, see them in orthogonal planes, stabilize it, and then fix it. Whether you use an intramedullary or an extramedullary implant, it doesn't matter. And of course, the gold standard is to do a bone grafting. Now, coming to a few principles, many fixation strategies are there, almost similar to what you use in the acute fractures, whether to use an intramedullary or an extramedullary implant. So how do you choose what implant you want to do a revision in these cases? The first and foremost point you should have is this implant should give you stable fixation of the proximal fragment. This is first and foremost. There's no compromise on that. The second thing is that the proximal fragment or the fracture has to be well aligned. You have to avoid varus, you have to avoid flexion. Make sure that the tip of the trochanter and the head of the rotation, center of the head of the rotation is in the same line. So use an IM nail when the proximal fragment is large and it has minimal bone defects in the head or in the neck region, and the proximal fragment is non-copious. An example, this was a subtrochanteric fracture fixed with an ender's nail, obviously gone into non-union. So if you have a carefully look at it, the proximal fragment is slightly longer. There's no big bone defects in the head or nail. These fractures can be easily treated with an intramedullary nail. When do you use extramedullary implants? I'm talking about the fixed angle divides. Whenever the proximal fragment is very short, there are large bone defects in the head and the greater trochanter, then is the time to use the extramedullary implants. So this is an illustration where an extramedullary implant has been used. If you look, the nail has made a big hole in the trochanter as well as in the head and neck. So in such cases, an angle blade plate is your savior. Is there any role for arthroplasty? Yes, in elderly, low-demand patients where there is some articular damage or there is an implant cutout, and arthroplasty, it can be done. Coming to the other principles, what are the other surgical principles? Indirect reduction, what works in acute situations will not work here. What will work here is direct reduction. You have to open up the fracture, you have to get rid of all the tissues or the debris which is there in the non-union side. You have to reduce it under vision and then align the fragment. The other principle is compression of the non-union side. You have to compress the non-union side. You cannot afford to leave any gap there. This can be achieved by, if you are using a plate, by the compression screws in the plate. You can use an articulating tension device, or if you are using a nail, make sure that the non-union side or the fracture sides are co-opted well, and make sure that they're impacted before you actually lock them off. Bone grafting, gold standard is the autologous iliacrest bone graft. The only situation where you can probably get away without bone grafting is in a hypertrophic non-union, but otherwise for the rest of the cases, bone grafting is indicated. This is a very good paper by Peter Giannidis from Leeds, where he talked about the diamond concept. I'll not go into the details. He achieved union in almost all his subtrochanteric non-unions with hardware failure. His concept is, apart from a good biomechanical stable environment, he also used osteogenic, osteoconductive, and also as osteoinductive factors to get the desired results. The other point, probably one of the last principles, sometimes we do see a non-union, but the implant is intact. Now, whether to retain that implant or whether to take it off, in short, take it out. It has been proved in literature. The last of the few slides, one of my patients, older patients, osteoporotic, was on bisphosphonate therapy for a long time, got up from a chair, stumbled, fell down, had this low energy subtrochanteric fracture both sides. You can see the long leg films. This is the left side. You'll see the medullary cavity is actually staring at you. It's almost in 90 degrees of flexion. Fixed inadequately, without any stability. I would probably classify it as a poor fixation, both the sides. 9 months down the line, not ambulating well, lot of pain, lot of agony. Revised after 1 year, one side with a 3-month interval with bone graft, used a locking compression plate on the right side and an angle blade plate on the left side. So the last slide, for successful outcome in subtrochanteric non-unions, carefully evaluate the non-union and make a plan, restore the alignment, you cannot have any residual virus, you cannot have any residual flexion. Stable fixation of the proximal fragment, achieve good apposition of the non-union ends, and finish it off with bone graftings. Thank you very much.
Thank you, Dr. Praveen Rao. Please collect your memento.